The next important kidney pathology to mention is hydronephrosis. This is a condition that results from partial or complete obstruction of the urinary tract. Pressure builds up backward towards the kidney, leading to dilation of the renal pelvis and calyces with compression atrophy of the renal cortex and medulla. Obstruction can be due to renal stones, benign prostatic hypertrophy, cervical cancer, injury to the ureters which leads to scarring, retroperitoneal fibrosis, and vesicouteral reflux. Now let's move on to tumors that can affect the kidney. The first one is renal cell carcinoma, the most common renal malignancy in adults. It typically happens in men who are 50 to 70 years old. Obesity and smoking also increase its risk. It's often called clear cell carcinoma because the tumor consists of polygonal cells filled with lipids and carbohydrates. From which cells in the kidney do these tumor cells originate from? They originate from the tubule cells, and usually it's the proximal tubule. Symptoms of RCC, symptoms of renal cell carcinoma include hematuria, a palpable flank mass, and polycythemia. Polycythemia occurs due to what hormone being produced in excess quantity? Correct, erythropoietin. The final symptom is usually flank pain. The tumor invades the renal vein and then the IVC, sometimes causing lower extremity edema. It spreads hematogenously and metastasizes to the lung and bone. It has an association with a gene deletion on chromosome 3. Do you know what this syndrome is called? Von Hippel-Lindau syndrome. This syndrome is due to a mutation of the VHL tumor suppressor gene on chromosome 3. In terms of paraneoplastic syndromes, what other hormones can this cancer produce? EPO, ACTH, parathyroid hormone-related peptide. Treatment involves resection of the tumor and immunotherapy with antibodies. Prognosis is generally poor because the tumor is usually discovered late due to its position deep within the body and its resistance to chemotherapy and radiation. A renal oncocytoma is a benign epithelial cell tumor. On histology, you will see large eosinophilic cells with abundant mitochondria and no perinuclear clearing. Symptoms include painless hematuria, flank pain, and an abdominal mass. Treatment is removal of the kidney. The next malignancy is Wilms tumor, which is the most common renal malignancy in children. For this reason, we would expect embryonic cell types to be present in the tumor, such as primitive glomerular structures. It's typically detected in early childhood as a large flank mass with hematuria either by the parents or on physical exam, and it generally has a good prognosis. Now this tends to be a high-yield fact for the exam because of the association between Wilms tumor and two known suppressor genes, WT1 and WT2, which stands for Wilms tumor 1 and 2. Now if you think back to genetics, you'll remember the list of tumor suppressors. Do you remember which chromosome WT1 and WT2 are found on? Chromosome 11. You can remember this association by drawing out a W using the two outside lines as your 1s in the number 11, like this. Additionally, Wilms tumor can be a part of a syndrome known as Beckwith-Wiedemann syndrome or a complex of findings known as the Wagger complex, which involve the Wilms tumor, aniridia, genitourinary malformation, and mental retardation. Transitional cell carcinoma is the most common tumor of the urinary tract system. Although transitional cell carcinoma can occur anywhere in the urinary collecting system, it's much more common in the bladder or the ureters. On the exam, the question stem might describe a patient that comes to the doctor with complaints of blood in their urine, denying all other symptoms. This type of painless hematuria presentation is classic for bladder cancer. Now, would you expect casts in the urine? Well, no, because the bleeding is occurring after the renal tubules. One important thing to remember is that it's very strongly associated with smoking and also with the chemotherapy drug cyclophosphamide, which causes what? Correct, hemorrhagic cystitis. Other associations are known with some more unusual chemicals like phenacetin, which is an old analgesic that's gone out of use, and aniline dyes, which is used as a precursor to many industrial chemicals. Flash quiz. A 58-year-old former smoker presents to your office with weight loss and hematuria. When you listen to his heart, you notice a prominent systolic flow murmur that is new to his exam. What is the likely diagnosis? Answer: renal cell carcinoma. The weight loss and hematuria in a former smoker should tip you off to a renal system malignancy. It could be in the kidney or the collecting system at this point, but the prominent systolic flow murmur indicates that this patient has a high hematocrit and very viscous blood. This all ties together to suggest a renal cell carcinoma that is producing excess erythropoietin. Squamous cell carcinoma of the bladder results from chronic irritation to the bladder. Can you think of some things that might cause this type of chronic irritation? Schistosoma hematobium, a bladder infection common in the Middle East, chronic cystitis, and chronic nephrolithiasis. Smoking is carcinogenic in general, and it increases the risk of bladder cancer as well. The chronic irritation leads to squamous metaplasia, which then leads to dysplasia, and eventually squamous cell carcinoma. Acute infectious cystitis is inflammation of the urinary bladder. Symptoms include suprapubic pain, dysuria, urinary urgency and frequency. Systemic signs such as fevers and chills are usually absent. Risk factors include female gender due to the shorter urethra, sexual intercourse due to the increased likelihood of bacteria being introduced into the urethra, and indwelling catheters. These catheters make colonization by an infectious agent easier. The most common cause of acute infectious cystitis is E. coli. Other causes are Klebsiella and Proteus mirabilis. Proteus species cause the urine to have the scent of ammonia because it produces which enzyme that also leads to staghorn calculi? Correct, urease. And what would you treat this infection with? Fluoroquinolones, usually ciprofloxacin as the first line. Unless you have a pregnant patient, then you'd want to use nitrofurantoin. Some high-yield gram-positive bacteria that can also cause UTIs are seen here in this image. Lab findings will include a positive leukocyte esterase test due to the presence of white blood cells. Nitrites will be present in the urine with gram-negative organisms like E. coli. Finally, sterile pyuria and negative urine cultures may indicate an infection with Neisseria gonorrhea or Chlamydia trachomatis because both of these organisms are intracellular. The first time you see a patient with CVA tenderness, you will never forget it. Tapping their CVA will make them jump right off the table. Now, why do patients feel pain in this region? Well, the kidneys are retroperitoneal organs and therefore will feel pain in the back. Causes of acute pyelonephritis include ascending UTIs and vesicoureteral reflux. How else could a pathogen reach the kidney? Well, hematogenously or through the blood. Risk factors for pyelonephritis include indwelling urinary catheters, urinary tract obstruction, pregnancy, and diabetes. A quick mnemonic I use to try and remember these is COPD for catheters, obstruction, pregnancy, and diabetes. Complications include chronic pyelonephritis, renal papillary necrosis, and perinephric abscess seen here in this image. Treatment is obviously antibiotics to cure the infection. Now, chronic pyelonephritis doesn't happen unless there's some anatomical abnormality, like vesicoureteral reflux or chronic kidney stone obstruction. This leads to repeated infection. In this case, the kidney is infiltrated by lymphocytes producing white cell casts, and it becomes fibrotic over time. This leads to corticomedullary scarring with blunted calyces, and the kidney begins to look like thyroid tissue under the microscope due to the eosinophilic casts.